Hello and welcome to our podcast Pager. I'm George Milner.
And I'm Stan Dale.
Tune in to hear us talk with some amazing people about the subjects changing medicine today. Since the first public and successful use of ether anaesthesia in 1846, anaesthesia has been at the forefront of medical science. In 2013, there were nearly 2.8 million cases of general anaesthesia in NHS hospitals. My guest today is Dr. Emery Brown, who's here to talk about the field of anaesthesia today and where it may see itself in the future. Dr. Brown is a Professor of Medical Engineering and Computational Neuroscience, as well as a Professor of Health Sciences and Technology at MIT. A practicing anaesthetist and research scientist, he is also a Professor of Anaesthesia at Harvard Medical School and Massachusetts General Hospital. Dr. Brown, welcome. It's a pleasure to have you with me today.
Thanks for having me, George.
So I'd like to start, if I may. Your CV is too long to read off in this podcast, but you are a clinical anaesthesiologist and also a research scientist. So I was wondering, how do those two aspects of your career play off against each other?
Well, right now they're completely integrated. So I practice anesthesiology at Mass General Hospital here in Boston, and I also conduct research on how anesthesia works. And that I do in two places, at Mass General, where I have a lab, and also over here at MIT. So in addition to, I practice anesthesia now, practice anesthesiology now, and then I come back to the office and I try to figure out, or the laboratory, and try to figure out how does it work, or how can we make it better.
And going on to your clinical practice, what do you think we can expect in the future? Will anaesthesia look the same in 20 years' time? Going into what will the role of anesthesiologists be, do you think?
I certainly hope not. I think the role is still going to be as integral as it is now in medicine. Medicine will evolve, and I think the role of the anesthesiologist will evolve. I see a number of potential pathways. I think we'll have better control of the process of anesthesia. Right now, we can't really disambiguate side effects from principal effects because of what we're doing. It's a given you're going to have a certain number of side effects. I think we'll be able to design more precise ways to deliver anesthesia, control the brain, so people are only anesthetized to the extent that they need to be. And this is a biased opinion, I'll admit right up front, but I think anesthesiologists who work in the intensive care unit are probably some of the most complete physicians around, because they have experience working in very acute situations like the operating room, but then they also have very complex patients that they take care of in the intensive care unit. And I think that role is going to become more and more important as intensive care unit medicine gets to be even more involved. And I see anesthesiologists playing even a greater role there in terms of pain, in terms of cardiovascular physiology, infectious disease, and then bringing the skills that we're very good at in the operating room to the intensive care unit.
So very much you see as anaesthesiologists working alongside artificial intelligence in the future rather than being usurped by it.
Yeah, I think that, it's very difficult to predict where artificial intelligence is going to go, because I strongly suspect it's going to be led by where the successes occur. A success happens in a certain area, then you're going to have a herd, move in that direction. I think that there are certain things where the artificial intelligence can help us. They'll help us deliver care better, maybe interpret data faster and use it in real time. But we have to be careful to draw the distinction between using just algorithms or trying to replace it in situations where there's clear physiology. And I think that the need to master the physiology is still going to be there, and to be able to use it on a sort of in taking care of patients is still going to be the physiology, the anatomy, the pathophysiology.
Certainly anaesthesia has been at the forefront of improving patient care for a long time, and it's often been said that mortality rates have decreased by a factor of 10 since the 1970s and 80s. But also there's been some debate within those statistics over when people say mortality is at 1 in 50,000 and 1 in 200,000. There are some questions around those statistics.
Well, I think the challenge is, so here's what happens. Anesthesia care improves, so you're able to take care of sicker patients. And saying that a death is attributable to something associated with the anesthesia, it's very difficult to separate out from the fact that they had other interventions, they certainly had anesthesia, but then you also had a very sick patient. So I think it's extremely difficult to disambiguate. What is clear is that anesthesia, the field of anesthesiology, made a tremendous improvement in patient care when it adopted monitoring standards. And that happened in the mid 80s, around 1985. They were standards for, and they're just very basic things, saying that if you're having anesthesia, you have to monitor heart rate, blood pressure, temperature, and then subsequently oxygen saturation, oxygen delivery. Seemingly obvious, but it wasn't required, right? So that was put forward by the Harvard anesthesia departments in 1985. It was adopted by the American Society of Anesthesiologists in 1986, and shortly after that it became a standard, kind of worldwide. After that, we did see improvements in anesthesia-related morbidity, and it happened because we're formally paying attention. So you can imagine if we come up with the next way to formally pay attention, which is guided by AI, let's say, we may see like further improvements. But that alone won't be good enough, because anesthesia still remains very crude as it's given now. So there'll be a limit to how much you can make improvements just by monitoring what is in essence still a fairly crude process. You have to change the process.
Of course. So 20 years' time, for example, what sort of monitoring processes do you think we'll look back on and say, why weren't we doing it then?
Well, I think a lot of them will be the same, but for example, I'll give you for instance, like right now, you monitor blood pressure. It's done by a cuff, right? And it cycles, let's say, every 3 minutes. And you can monitor blood pressure directly by putting it in an arterial line, but that's invasive. Suppose you could come up with a way to monitor blood pressure non-invasively that gave you the arterial waveform. Huge, right? That would be so that's a solvable problem, So there are things like that which I think offer a lot of possibilities.
And going back to one thing that you touched upon, it strikes me as slightly strange, given the total number of patients who go under anaesthesia each year just in the United States, that we don't know more about what the long-term effects are, for example, in the aging brain or in the very young brain. I know in 2016, the FDA actually issued a caution for use of anaesthesia in the under fives.
Yeah, so, well, it depends upon how you view the way anesthesia. So I would say if you look at the sociology of anesthesia research and anesthesia practice, it becomes very clear why that's the case. And it's because they've been decoupled. See, in anesthesiology practice, the process is viewed as something which is, or has been viewed as something which was not only unknown, but perhaps unknowable. And then the work that's been done and was being done in research would come up with targets where the drugs were binding in the brain or the central nervous system, but that didn't tell you why it produced the behavioral state change. So there's a disconnect between what people are doing in the research laboratories and then what people are practicing. So the question is, how do you link those? And that's one of the things that we've been working on, because you can actually see that the drugs produce oscillations. We can understand very well why the oscillations come about by understanding the brain circuits where the drugs are acting. So now you have something that you can actually study, the receptors, the circuits, the oscillations, which actually relates very directly to what you see in the operating room. And I think that's the sort of bridging that's necessary in order to move the field forward. And I think it's only in the last few years that I think the field has, and I'll just say it, has really brought neuroscience into the study and the practice of anesthesiology.
So as someone whose work spans both clinical practice and research, do you feel that in the future we're going to have to be more careful about who we put under anaesthesia and perhaps more sparing with it?
No, I think that my hope is that, well, I think what's going to happen is as we get better with it, we're going to try to go after sicker patients, and that's what we've seen historically. I think that what I'd like to see that occur because we now control precisely the states that we'd like to have, and not saying, okay, I've given you enough sevoflurane, you look like you're out, okay, I think we can operate, right? It'd be great to know that we've turned off point A in the brain. Now that we're done, let's turn point A back on, and the person comes right back. that's sort of my dream for the next 20 years that I'd like to see happen. If we're able to do that, then it'll allow us to, again, take care of a whole nother level of ill patients, right, that we probably can't take care of, as effectively now. And without the attendant side effects, because pretty much it's a given, if I give you any of the commonly used anesthetics like propofol or sevoflurane, your blood pressure is going to go down. Right? So can we uncouple those? So if you could uncouple those, that would be, or you're going to stop breathing. So right there, if you're able to uncouple those, and just to make it even more concrete, patients that have sleep apnea, who as soon as they get a little bit of sedation, their airways close off. So if, for example, you're able to anesthetize those people and they kept breathing, just normally, certainly for sedation cases, let's say like colonoscopies or, minor procedures, that would be a huge advance. So there's where I see us being able to maybe take better care of, sicker patients take care of them better than we're doing it right now.
And certainly in terms of side effects, I know that opioids are a buzzword in the media now, but they're very commonly used in anesthesia, in fact, in the majority of cases, if I'm right in saying. But do you see anaesthetists having a role in the current opioid crisis?
I think we all have a role as healthcare providers if we don't think carefully about dosing any drug, and opioids just happens to be one of them. I'm sure we as anesthesiologists have played some role, and I'll leave it to the sociologists who study these phenomena more than I have to sort of say where the bulk of the responsibilities may lie. Where I see us being able to help with this going forward is in realizing that opioids may be among the best drugs to administer to treat pain or to control nociception, meaning the transmission of harmful stimuli within the central nervous system. But there are other drugs which work also. And in combinations, either with opioids or without opioids, you may achieve a state which is just as adequate, and you avoid the use, or you certainly dramatically reduce the use of opioids altogether. There's where I see a lot of possibilities. And opioids made and makes it easy for us, but we pay a price potentially, down the line.
Of course. And would you say that you're excited for any other classes of drugs to be introduced in the future, or perhaps reusing currently licensed drugs?
Well, I guess what I'm excited for is a conceptual framework which we call multimodal anesthesia. So in multimodal anesthesia, what you do is, I'll just be frank with you. I changed my practice in the last 3 years. And I'm going to say something which is going to sound ridiculously obvious, but I can say I didn't practice this way before 3 years ago. You need anesthesia because it hurts, right? You don't need to be unconscious. You need to have the treatment because it hurts. So we should put our emphasis on trying to control the pain circuits. And if we do that, and so since there are multiple points where we can enter and control the pain circuits, the opioids being one of those entry points, why not use multiple drugs to do that? Now, when you do that, what happens is those drugs also decrease arousal, which means that the amount of the drugs that we would typically use, like propofol or sevoflurane, to decrease arousal is less. So this idea of multimodal anesthesia uses the fact that we can attack the pain system at multiple different points, and we get some degree of decreased arousal as a consequence, and therefore what we're able to do is administer less of those drugs which make you unconscious, which may be adding to, certainly contributing to some extent to phenomena like postoperative cognitive dysfunction and delirium.
Certainly multimodal anesthesia is currently mainly seen as pharmacotherapy, but also we've seen recently moves towards non-pharmacological methods being used in that, such as hypnosis, meditation, or even I saw one on virtual reality recently for controlling labour pain. Do you think that these will be more and more adopted?
Oh, I think so. I think so. I think that there's no reason why they shouldn't be, and I'm very open-minded. I'm very open-minded about those approaches. I think we're going to have to learn more about the neurophysiology of those approaches before we can really apply them, effectively. Just as, any good hypnotist knows, right? There's some people not hypnotizable, I guess would be the word, right? So you could go there in the operating room and go, okay, I'm going to hypnotize you now, and the guy's not hypnotizable. Okay, can you go under the spell, please, so I can hypnotize you? So I think we got to learn a little bit more, certainly on the list. Hypnosis, meditation offer a lot of possibilities. One of my colleagues at the Beth Israel Hospital, Bala Subramaniam, is studying the use of a meditation scheme preoperatively to help reduce the need for pain medications postoperatively. So I think all of these things are on the list of possibilities, and we should pursue them and keep our minds quite open about the potential that they may have.
And once greater understanding and evidence is there, do you think will it need any more selling? Because certainly I can imagine coming to my doctor and them saying, I'm going to hypnotize you, and me thinking, actually, I was here for anesthesia, this isn't anesthesia. Is there going to need to be maybe a cultural shift?
No, I think, it's just like with everything, it's just a matter, if we can show that it works, then, so, like I was saying before, a good magician who does hypnosis, right, can figure out who the people are that he or she can hypnotize. And if you're out on a cruise ship giving a show like this, and you make a mistake and figure out it's someone who isn't hypnotizable, you think they are, when in point of fact they aren't, that's going to be huge. So there are things that they can tell us already, right? So you learn to apply this to the people for whom you think it would work. And then maybe as you learn more about the people in whom it seemingly works now, maybe you could figure out ways to expand that set of people to whom it could also apply. So totally open-minded. But multimodal drug therapy is going to be helping us out a lot sooner than I think hypnosis and meditation.
And perhaps we've given anesthetics a bit of a bad rep for causing side effects, but there's been quite a lot of literature on possible positive effects, not necessarily within surgical anaesthesia, but xenon, for example, an anaesthetic gas that can be good for patients with brain injuries, or even anaesthetics, an event called anaesthetic preconditioning, causing decreased susceptibility of the heart to periods of blood loss. Do you see a role for anaesthetics perhaps outside what was considered their original sphere?
Oh, very much so. I think the most compelling example is ketamine, now used to treat depression. So low-dose ketamine, very small dose. We're talking something on the order of, for a 70-kilogram person, 35, 40 milligrams given over a period of 45 minutes. And someone who's chronically depressed, they've been depressed for years, maybe been through 2 or 3 major drug regimens. All of a sudden, within a short, and just as I'm sure you know, for standard depression therapy regimens, it takes weeks or months for them to really have effect. Now imagine someone who's chronically depressed and they switch to a new drug regimen. They go through this point in the first few weeks where they're highly suicidal very often because they have despair, understandably. So imagine you can make them feel good right away and have it last for 10 days, 2 weeks or something like that. Those are the types of results that have been gotten from convincingly now from a number of studies using low-dose ketamine. That's huge. Ketamine is probably one of our oldest anesthetics. And
probably one of the most commonly used drugs in the world.
Commonly used. In fact, it's on the World Health Organization's list of essential drugs. Because if you were going to go to a remote area to give anesthesia care and you could only take one drug with you, you would take ketamine. But that to me is one of the biggest successes of application of an anesthetic drug in wide use for anesthetic purposes to help solve a major health problem elsewhere. And there may be other repurposing possibilities around. So there's been some demonstrations that, continuing on the theme of depression, right? Just replacing ECT, electroconvulsive therapy, with a dose of anesthesia. So instead of getting 3 doses of electrical shocks over a period of, let's say, a month or a month or 3 weeks or something like that, just anesthetize you for 20 minutes and then have you come to. So there's a group out in Utah which has shown that can be just as effective in reducing depressive symptoms.
And do you see perhaps drugs moving in the opposite direction, so to anesthesia, from fields classically associated with psychiatry, for example?
I think so. I think so. I think there's some real possibilities. there as well, but they're really in very infant stages, I think. I mean, the ketamine story is a great one because now they're ketamine clinics, believe it or not. Just recently, Johnson & Johnson has come out with S-ketamine, which you can administer intranasally, for treatment of depression.
So that's an optical isomer of ketamine, which has reduced hallucinogenic effects.
Yeah, supposedly.
So moving on slightly, you've been very clear on the fact that anesthesia is different to sleep. But just on the theme of insights into other fields, does anesthesia give us any insights into sleep and perhaps how we could modulate that in the future?
I think it does. I think, so the first thing, I'll just give you a parallel. So like right now, let's say we didn't have anesthesia. And one phenomenon that you notice in sleep when you're in the deepest stages of sleep are slow waves. That's the deepest stage of sleep, what we call now non-REM stage 3, non-rapid eye movement stage 3 sleep. The other time you would see slow waves aside from sleep would be in patients that have coma. However, with anesthesia, all the anesthetics produce slow waves. So if you think mechanistically about why that's the case, you have a way to actually start thinking mechanistically about how slow waves are produced, and maybe a way of starting to design new approaches to sleep. So it opens up a whole new kind of perspective on, on sleep and brain inactivation. So I think it tells us a lot. Or, as another illustration, for the drugs which work by enhancing inhibition through GABA, the neurotransmitter GABA, you see oscillations in the 10 hertz range. We call them alpha oscillations, primarily in the front of the head. And again, so this is a very reliable way to produce 10 hertz oscillations. So once you start, if you can understand the neurophysiology of these, then you have a way of starting to decipher some aspects of 10 hertz oscillations that show up in other settings. Like once you close your eyes, if you close your eyes, like here right now, you'll produce a 10 hertz oscillation in the back of your head. It won't be in the front. So these mechanistic insights that we start to gain about anesthesia may help us understand a lot of these other neurophysiologic phenomena that are happening in other settings. So I see it as an enormous opportunity in this regard to understand the brain better.
And certainly I've seen you present a spider diagram with anesthesia at the centre and all the specialties around the outside. And are there any other aspects of general anesthesia that make it useful for studying in different fields, would you say?
Yeah, like in that diagram that you saw in my talk a couple weeks ago. So there are a number of links. Like, interestingly enough, you can give a low dose of a drug like methotrexate, which is a barbiturate, or alfentanil, which is a synthetic opioid, and those drugs will induce seizures. And we use them clinically when the neurosurgeons are operating, trying to find a seizure focus, and they can't identify it. So you give there's a pretty established protocol at Mass General using alfentanil to do that. At a higher dose, methotrexate is a barbiturate, so it can actually be used to treat seizures. I mean, why is this? I mean, fascinating, like fascinating question. And, as another illustration, one of the things that everybody's paranoid about is being placed in a situation where they're anesthetized but awake.
And whilst making up a small proportion of cases, it makes the media.
Extremely small set of cases, but when it happens, you hear about it. Well, for a number of years, anesthesiologists were doing this, unintentionally, by using a combination of fentanyl and droperidol. Droperidol is a butyrophenone. Fentanyl is a synthetic opioid. And those two drugs, when given together, place patients in a state of external calm. Look like having no discomfort, completely tranquil, stress-free, when in point of fact they're locked in. And when the patients come out of the state, they're trying to tell you, like, I was locked in there, but I couldn't tell you. Fascinating idea. Why is that? I mean, what happened to them? Where were they? So there are many situations like this, and actually, as a consequence, the use of those two drugs together, combined pharmacologically as one drug, was actually abandoned once they realized that this was happening. It used to be called I can't remember the name of it, but when fentanyl was released in the United States, it was felt that it was too potent to be given by itself, so it had to be given in combination with droperidol, and this is what happened. So I mean, that from a pharmacologic, from a neuroscience standpoint, that's like a fascinating. What happened to these people? Where are they when they're locked in?
And focusing on the why, definitely one of the big questions in anaesthesia is, how do these drugs work? So it was perhaps a shock when I heard you stand up and say, I don't care how they work. I don't care how they work necessarily on a molecular level, but I'm more interested in the circuits.
Well, let's be clear. I do care how they work on a molecular level. Now, what I said was, we have to, because what we actually do is, to be very clear, I care profoundly to work on the molecular level.
I'm sorry, I've twisted your words.
Yes, exactly. So I'm untwisting them. That's all right. Don't worry. I care tremendously because that's the first thing we take advantage of. These are where these molecular targets are, so that's where they have to be hitting in the brain. Now, how are those parts of the brain connected to other parts of the brain? And then the other piece of the information you have is, what dynamics do you see in the EEG, or when you record, let's say, electrophysiologically in animal studies, what do you actually see? So those three pieces of information allow you to put together mechanistic descriptions of what's going on. And so, just as I was saying before, you see alpha oscillations form in the front of the head. All right, so why should that be the case? Well, they're very rich thalamocortical connections, particularly frontally. Generating an alpha oscillation in the cortex, straightforward to do. All you have to do is essentially continue to continually induce GABAergic inhibition with, with your anesthetic. The same thing will happen in the thalamus. The two couple, and you get an oscillation which goes back and forth. Now, but you lose consciousness, right? So why would you lose consciousness? Why would that contribute to your losing consciousness? Well, if I tie up your thalamus, which is a major way station for communications going everywhere, it's probably going to be very hard for you to maintain normal mentation. So I say it this way because in figuring out or coming up with this potential way that the drugs are working, I needed the molecular targets to begin with. I needed to know the circuits, the anatomy there, but I also needed to know the neurophysiology and what the dynamics are like. So that when you put those three things together, we can now have a principled discussion about how the drugs are working, and we can move beyond saying like, oh, I don't know. I mean, because nothing drives me bonkers more than that. That's just like, in 2019, we shouldn't say that anymore.
And understanding those circuits better, could there be any reverse engineering from that to design maybe the next generation of drugs?
That's the idea, very much so. Very much so. Once you understand where the circuits are, which ones are most relevant, which ones are also maybe the most accessible, because maybe the most relevant ones are maybe not the ones that are easiest to get to, I think you can start having a whole different conversation about what anesthesia looks like, or think about how you might design it.
And perhaps take on an even sicker cohort of patients. Anesthesia
The sicker cohort of patients, right.
To deal with in the future.
I mean, just think about it. Again, we just take it as a given. I give you enough propofol, you're going to stop breathing. But if you look back, before we had drugs like propofol, and we did inductions the way we do, we would just put a mask on the patient, let them breathe themselves under with ether. And they would continue breathing the whole time they were having surgery. So you don't have to become unconscious under anesthesia and stop breathing. We've known that for years. But we've never gone back and said, wow, that's an interesting phenomenon. You become unconscious, but you're still breathing. Now, how did that happen? How did the circuits turn off in such a way that it preserved respiration? So it's like it's looked at as one of those things like, oh, well, it just happens, That's a cool question. That's a very cool question.
With your background in computational neuroscience, do you feel that the brain really is a computer? That it can be broken down into individual circuits?
I'm reluctant to say that. I mean, I think that it's a nice, it's a nice metaphor, But I think the metaphor starts to break down very, very quickly because, so just take a single neuron, right? So let's think of in your metaphor there, let's think of the single neuron as being the computing unit. So you put together a lot of different neurons, some inhibitory, some excitatory, some with this neurotransmitter, some with that neurotransmitter. Now you have your computer, right? Your brain computer. But take that one neuron. That neuron is a mini dynamical system in and of itself. Its dendrites extend and retract. Its metabolic state changes. The cell volume actually changes. It produces, as I said, more or less like neurotransmitter. So you have a mini dynamical system at a number of different levels. Oh, you have dynamical systems at a number of different levels. Computer architecture is not built that way. So that's what's so amazing about the brain. Yeah, we can look at it, so the question then becomes like, we can think of action potentials going down the nerve system, electrical impulses being transmitted that way. But we also know that electrical information is transmitted through gap junctions, right? So it's really a gross oversimplification, I think, of what's going on. And I think if we get too caught up in the computer metaphor and we fail to continue to marvel at like the neuroanatomy and neurophysiology, we're going to make progress less quickly than we would otherwise. So that's why I'm just careful about adopting that metaphor.
Certainly there has been a lot of interest in mimicking the brain. It's an amazing thing, as you said, but there's been interest in perhaps changing our computer networks to be more like the brain.
Mm-hmm.
So do you think our models will be better in the future, and they'll actually be able to, rather than modelling it on a kind of a gross scale, actually look at a more microscopic scale?
I mean, possibly. I mean, I think that, there's some amazing things that are happening now in computer science, and amazing things which have happened by emulating the brain, just, like you're suggesting. But it would be very interesting to see like a computational unit that was constructed so that, let's just, to make it concrete, let's say on 4 different maybe spatial scales, on 4 different time scales, was composed of computational units. I mean, that would be wild. I mean, that to me would be sort of really more mimicking what the brain is doing. So possibly, but
perhaps a question for many years down the line.
Yeah, maybe not that few. We're learning a lot very, very quickly about how the different parts of the brain are working and these sort of computational phenomena. I guess what I'm just suggesting, kind of from a bigger picture perspective, is that let's continue to study the brain, but just keep our minds open, as opposed to like saying, okay, now we've got it, it's just a computer. Because again, I think that could lead us to become complacent and miss some obvious things too soon.
Moving on, if I may, it's often said that the real money in anaesthesia is not in putting people under anaesthesia, but it's at waking them up afterwards.
Mm-hmm.
And I know that you've done some work into looking at bringing people back from anaesthesia.
Yeah, I mean, that's one of my favorite sayings, right? You don't pay me to knock you out, you pay me to bring you back, right? I think that's very important. Almost anybody can knock you out. I think this is an area where we have to place a lot of emphasis because of brain dysfunction after anesthesia. It's a real problem. Depending on which study you look at, 20 to 40% of patients over the age of 60 will have some form of brain dysfunction after anesthesia. Delirium in kids, 25% of kids who are anesthetized with, let's say, any of the ether anesthetics will have some degree of brain dysfunction after anesthesia. And I think that while there's some things that we can do to try to mitigate it, the monitoring which we've talked about, that I talked about in my talk a couple weeks ago, of using the EEG to really track the brain states closely, I think that's going to help us. It won't be the be-all and the end-all. Turning the brain back on, as I was suggesting in that talk also, is perhaps something that we can consider. But I think ultimately what we have to do is we have to come up with different paradigms for anesthesia. Because these are all fix-ups. These are like, okay, we put you in this state we really didn't want you to be in. Now let's fix it up. I'll try to monitor a little bit better. I'll try to turn your brain back on. But fundamentally, we're still doing something very crude. We're not going into precise parts of the brain, controlling the dynamics there, controlling the dynamics perhaps in another part of the brain. The surgeons say, I'm done. You go, okay, I'm done too. Oh, Dr. Brown, good to see you. That was a really great anesthetic experience I had there. I didn't remember a thing. I mean, that's what you want. As soon as they're done, have them pop right out. And that comes from fundamentally changing their approach. I think having ways to wake people up, giving drugs that maybe stimulate the brain, sure, I think it's a cool idea, and I'd love to see us do those sorts of things. But I just want to see us really just change the fundamental approach.
So changing the fundamental approach, would that come with more precise drugs or from not using drugs in the first place?
It may be all of the above. It may be some combination of using drugs to get you into one state and then doing something else. But I think that one of the things that we're starting to learn about is we're starting to learn more about ways to use maybe stimulation ideas to control the brain. Now, clearly they can't be invasive for anesthesia for the purposes of surgery, but what they do tell us is it's possible to deliver stimulation to very precise areas of the brain and change what the brain does. And the key thing with anesthesia is you want to put someone in a state so that you can maintain it for a sufficiently long period of time so they're insensate to the trauma of surgery that they're undergoing. So that's a harder task, right? But conceptually, the sorts of things that people are doing with deep brain stimulation just need to be extended to the case of anesthesia. I think that there are tons of possibilities there.
I think one final question to finish off with, we've had a lot about protocols, artificial intelligence. So I'll change tack slightly and ask, do you think amidst all of this, the art of medicine is being lost in a way?
No, I don't think so at all. Actually, let me be clear. I think it can be lost because, like right now, I often tell my patients, I'm sorry I'm not looking at you while I'm talking to you, but I have to look at the computer screen because if I don't put this information in the computer, we can't go ahead with your surgery and your anesthesia. And that's very, very annoying. So that the interaction with the patient is changed, dramatically. When we think of the master clinicians, of days gone by, they had seen so many patients, they had intuition about what was going on. And, they had intuition about the pathophysiologic states of their patients. What I hope we'll do is we'll use things like artificial intelligence or electronic health records to help just extend our ability to have intuition, to cull information, and then develop those same sorts of insights, but on a broader range. If we don't use it to enhance our intuition, what we do is we just say, let me see, here are the symptoms, can you tell me the disease or what's going on? Oh, great, thank you, right. Then yes, I'm in mortal fear of that having a tremendously negative impact on medicine. But if it allows us to extend our ability to understand and gather information, I think it opens up a tremendously bright future for the next generation of practitioners.
And hopefully that's a bright future we'll all be heading into. Dr. Brown, thank you very much. It's been a pleasure to speak with you.
Pleasure's mine. Thank you. Thanks for the invitation.